If there's anybody out there, can anybody hear me? Megan, can you hear me?
Yes, I can hear you.
Okay, thank you so much, Megan. Appreciate it. All right, let's get started. This shouldn't take real long. We're going into the positioning part of this, and we're just going to run through positioning real quick of a few different body parts. With your study guide, the study guide does have that in it, but I just wanted to touch on a few things, and we'll do that today. And then next week, we'll go through the rest of the positioning. But anyway, I appreciate you guys being here. Just give me a sec to get to the right screen, and away we go. All right, can you guys see that okay?
Yep.
Perfect. Okay, so welcome to LSRT study group number 14. Upper and lower extremity positioning. And as you guys know, we do a lot of x-rays of upper and lower extremities, especially feet, ankle, knees, anything up from the fingers, we do a lot of. So these are important that you know the ins and outs of the positioning. And it's important that you practice the positioning. We did shoot an ankle positioning video last night, which I'll be posting a little bit later today. I'm hoping to have a complete notebook of positioning in the next 3 or 4 weeks, hopefully, on the Sterling Hub. So, and then going forward, this is going to be put into a program where it's going to have its own home where we can go through all of these study groups and get you guys ready to take the national board exam. I'm going to have various practice tests and things of that nature that go along with the study guide. If you haven't received a study guide, please get with your manager. I know the people up in Boise and Lewiston, I did send a whole bunch of books up that way. I hope that they have been distributed at this point. If not, please let your manager know or let me know, and we will definitely get you a study guide out. Okay. All right, let's get started here. So just a quick review from last week. We just went over, imaging software, the image or the technique console that we use, and the program that we use as far as our imaging program. So, and we basically went over everything, all the buttons, and I'm just saying, get to know your imaging software. Okay, know how to navigate around to where you need to be. If a problem comes up or an image comes up sideways or backwards, you know how to make that look right, anatomically speaking. So, most of our imaging consoles work with API techniques. There's one that doesn't right now, which is Rock Springs, and I apologize for that. I'm working on getting that fixed for you guys. But, learn to trust your techniques that are in your console. You very seldom need to change anything unless you've got a really small patient or a really big patient. So just get to know your techniques. And there always is a backup paper technique in every imaging or imaging suite. So we talked a little bit about post-processing, what to do with an image after you take it and how the image should look. And we talked a little bit about contrast and density. And that is something that you're going to get much better with lots of practice. So you guys are doing great, though. We talked about, get to know your anatomy, your body parts, be familiar with the techniques for each body part, and where they're in your console already, you're going to get familiar with those. It's my opinion, every time you set a technique, an API technique, on your console, look at it. You know, you can start to commit that stuff to memory and have a good idea of what your technique's going to be for each body part. And I'm not saying you have to memorize it, but just become familiar with it. You know, I'm to the point now where somebody could give me the weight of somebody and their stature, and I could usually come up with any technique for any body part. And if you ever have questions, please reach out, and I can usually get you in the body part in the ballpark to make your image look good. So we talked about PAC system, picture archiving and communication system, and DICOM, digital imaging and communication in medicine. They're the backbone of what we do. Without PACS and without DICOM, we would be back in the arc ages with plain film and filing film. It was a mess, and it was a lot of work. This, you know, the way things are set up now, we can send images to anywhere in the world at any time. Any doc or patient can look at an image from their own computer, and that's pretty awesome. You know, and as far as storage goes, it's awesome. We can pull images up, you know, from 5 years ago on demand, and that makes our job a lot easier. Okay, but that's kind of some of the stuff that we talked about last week, and stuff that you need to be familiar with. Okay, so let's get into some image positioning, body part positioning, and I am just going to run through these. We're going to talk a little bit about each one. But these are here for your benefit, okay? And I know these are in the books already, but it's stuff that you need to know for the test, and it's stuff you need to know in order to do your job daily in the X-ray suite. So fingers, you know, the positioning, we need to know what projections we're taking. We're going to take a PA, an oblique, and a lateral, okay? Technique 50 to 55 kVp, mass 2 to 3. So we're not using a lot of technique, but we're going to get a nice contrasty picture. You have your central ray is 0 degree tube angle, so it's perpendicular to the image receptor, and the central ray is at the proximal PIP, or proximal interphalangeal joint. Okay, that's where your crosshair is going to be. Collimation laterally to the adjacent fingers, proximally to include the carpal-metacarpal joint, and distal to include the tips of the phalanges. Okay, now remember that when we're shooting fingers, we want to include the adjacent fingers, right? We never just want to have one finger there unless it's a thumb. We always want to shoot the finger next to it. So just for comparison's sake for the doc. Practical point, digital visualize to include the carpal-metacarpal joint. Alongside finger is included to ensure the correct finger identification. Okay, the concavity of the metacarpal shaft is equal. Okay, that's how you know if you have any rotation or not. The concavity in the mid shaft of your finger should look the same. So, okay, and that's what we're going to do today. We're just going to run through each body part, just upper and lower extremities today. We'll get into the spine and stuff, and skull and chest and abdomen next week. So hand, very similar. We're going to do a PA, oblique, and lateral. All these are done at 40-inch SID. Okay, central ray 0 tube angle, and the central ray is the head of the third metacarpal. Okay, collimation laterally, we want to include the entire hand, so skin margins both medially and laterally. Proximal, we want to include the carpal bones, or the distal radial ulnar joint, and the distal tips of the phalanges, of course. We just want to include the entire hand. Technical factors, KVP 50 to 55. We're going to do a low KV because we want a high contrast picture. Okay, that is indirectly proportional to each other, your KVP and your contrast. Mass 3 to 5. You're going to use whatever comes up on your machine. Your API technique is going to work fabulous. Okay. Always ensure the fingers are equal distance apart. You don't want any fingers overlapping each other or somebody crossing their fingers. Make sure the fingers are the same distance apart. The detector is high enough to avoid overlap of the wrist. Okay. Always include the wrist joint on your PA, oblique, and lateral. So you want to include the wrist joint with your hand. just so you know. Okay. Wrist, again, SID is 40 inches. PA, oblique, lateral. Okay, you're starting to see a trend here, right? So most of these images, we're going to do 3 images. A PA, a straight-on picture, an oblique, which is an oblique picture, and a side view, which is a lateral. Okay, the central ray is 0-degree tube angle. Okay, it's perpendicular to the image receptor. And your central ray is going to be the mid-carpal region. So you're going to put your central ray right in the middle of the wrist. Okay. Laterally, again, you want to include the skin margins. Distally, you want to include up to the metacarpals. Okay. So you're going to include the carpal bones all the way up the metacarpal to where it meets the phalanges, right? Proximal, you want to include 1/4 of the distal radius and ulna. Okay, just think about what you're shooting, and you're going to include that body part, of course, but you're going to include just a little bit above and below. Okay, practical point, it's easy to forget that simply lifting your hand up and placing it on the image receptor could result in substantial pain for the patient. More often than not, the pain has not been addressed yet. So we are dealing with people that are dealing with a new pain. So we need to be really careful with people and make calculated movements to take the pain away from the patient. And you know, the further you go along in X-ray, the more you'll learn how to do that, to take it easy on the patient. Offer to move things around to assist in positioning. Simple things like lowering and raising the table or the image receptor can help the patient tremendously. Okay, always keep that in mind. All right, and always remember on your PA view that you're going to curl your fingers under, which is going to place your carpal bones closer to the image receptor. Okay. Forearm is a long bone. You know, forearm, humerus, tib, fib, and femur. Those we only take 2 images. Okay, an AP and a lateral. So we don't do an oblique on long bones, just so we know. Central ray is 0-degree tube angle, and your central ray is mid forearm. Pretty simple. Distal to the wrist joint, we want to include the wrist joint, and we want to include the elbow joint. Lateral skin margins, pretty simple. Technical factors, you'll note that our KVP has gone up a little bit just because there's more to get through in the forearm than the wrist or the hand. Mass as well has gone up to 5 or 7. Okay, a practical point, the AP and lateral forearm should not be considered a view for evaluating any occult injuries of the wrist or the elbow due to beam divergence. Now remember, a few classes ago we did talk about beam divergence. So you'll note on the picture on the far right how that beam comes down in a cone shape, right? So when we get to the wrist joint and the elbow joint, we're actually not looking straight down into the joint. We're actually getting an angled view of that joint. So we can't see the wrist as well, and we can't see the elbow joint as well. So if the patient has wrist pain, you want to shoot a wrist. If they have elbow pain, you want to shoot an elbow, but never shoot just the forearm to look at the wrist or elbow. I hope that makes sense, because we are dealing with some beam divergence there. Elbow, 40-inch SID, we're going to shoot an AP and an external lateral and a lateral. Our beam is perpendicular to the IR, 0-degree tube angle, and our mid-elbow joint is our central ray point. Okay, collimation, superiorly, we want to include at least 1/3 of the humerus, and inferiorly, we want to include 1/3 of the proximal radius and ulna. Lateral skin margins, of course, and medial skin margins. Okay, technique, 60 kVp at 5 or 6 mass. At times, you know, elbows are tough because elbows really hurt patients, and it's a very movable joint. So in order for the patient to move that joint, it's going to be painful, especially if there's anything going on in there. So be really careful with your patients. You know, every once in a while, you're going to get a patient that can't fully extend their elbow. At that point, we're going to do 2 pictures, one with her forearm against the image receptor and one with her humerus against uh, the image receptor. Okay, so we're doing 2 images just because they can't straighten their hand out. Okay, and you can go back to the positioning video that I made, and I show you how to do that. But very important to know that you don't have to do it very often. Sometimes you'll get asked to take a picture of somebody that's in a 45-degree angled or a 90-degree cast on their elbow, and you'll have to take 2 pictures, one with her forearm on the IR and one with her humerus on the IR, okay, to get that elbow joint. Humerus, we love humeruses. They're fun to take. It's a long bone, so we're just doing an AP and a lateral. We're perpendicular to the image receptor again, and our central ray point is mid shaft of the humerus. And we want to include the top of the shoulder. We also want to include the elbow joint, right? And both anterior and posterior skin margins, and the lateral and medial, depending on which picture you're taking. So just make sure the entire humerus plus the shoulder and plus the elbow is on there. And, once again, it's hard to look at the shoulder and the elbow in these pictures. They need to be included. However, if you were having shoulder pain, you need to take a shoulder or a elbow just because of the divergent beam factor. So practical point, the humerus is positioned in AP, evidenced by the medial and lateral epicondyle seen in profile, and the greater tubercle is seen on the lateral aspect of the humerus. Okay, the shaft is abducted away from the patient's body, minimizing superimposition with the chest. Okay, often you will have to rotate the light beam. You know how you've seen me turn the collimator box, just so we can align it with the long axis of the humerus, kind of like you can see it's turned a little bit on these pictures, right? Anyway, yeah, humeruses are cool. So, and shoulders are awesome as well. Again, 40-inch SID, that's what you're going to basically be dealing with most of the time. Projections in AP, you're going to do a true AP, which is a Grashy view, a scapular Y, and an axillary view if possible. I'm learning a new way to do that on the Paxis 100, and I'm going to bring that out to you guys. And it seems to be working okay as far as getting an axillary view on the Paxis 100, which is awesome. Anyway, I'll show you guys that soon. So central ray, 1 inch below the coracoid process or 1 inch below the lateral clavicle at the glenohumeral joint. Okay, so it's kind of hard to palpate the coracoid process. So you're going to find the distal end of the clavicle, and you're going to go 1 inch below that, which is going to put you right in the middle of the glenohumeral joint. So that's where you want to center your picture. Collimation, you want to include skin margins, basically, especially on the lateral humeral side and the top shoulder side. You want to be able to see those skin margins. Medially, you want to be able to see the sternoclavicular joint, right? And you want to try, inferiorly to see the entire scapula if possible. So technical, we've kicked up to 70 kVp just because there's more mass to get through there. And our masses went up as well to 10 or 15. Practical points, there's much room for positioning error with shoulders. Okay, you need to pay close attention to your positioning skill and how much you have your patient angled. When you're angling for your scapular Y or your Grashy, a good 45-degree angle is going to get you a better picture. Just become familiar with what 45 degrees looks like. Like it says here, that the axillary view is difficult to achieve with the Paxis 100 machine, but it is possible. The scap Y view can be used in place of the axillary view if needed. So, but where the scapular Y is part of our protocol, you're going to get that anyway. So, anyway, the pictures are helpful on these as far as what we're looking for. Okay, clavicles are fun to take. It's a long bone as well, so we're just going to do 2 views. an AP and an AP cephalic view. On the cephalic view, we're going to angle our tube 15 to 30 degrees cephalic or towards the head. And our central ray is going to be the mid clavicle. We want to include the superior skin margins. Inferior, we want to include at least mid scapula, lateral skin margins, and medial the sternoclavicular joint. Or we need to include the entire clavicle. Okay. We're going to shoot those 70 at 10 to 15, depending on the size of the patient. You can go all the way up to 30 if your patient's big. On the cephalic view, the clavicle is flattened out. So you'll notice that when you do your angled view that when that picture comes out, the clavicle actually looks flattened out and it projects above the shoulder girdle. That's why we take it so we can see the clavicle a little bit better. This projection can often better demonstrate subtle clavicular fractures. If you don't want to angle your tube, you can always angle your patient 15 to 30 degrees backwards against the image receptor. Okay, kind of a lordotic type view. So very, very nice. Okay, let's do some lower extremities and we'll be done. Toes are probably one of my least things to image, and I don't know why. Maybe because they're so small. Anyway, so 40 inches, AP, oblique, and lateral. Technical factors, we've went down to 50 to 55 again, and 2 to 3. It's kind of like shooting a finger, but it's a toe. Okay. So central ray, 15 degrees cephalic tube angle. And when I do my foot positioning video, which is the next one I'm going to do, I'm going to show you guys a little trick how to not have to angle your tube if you don't want to. Anyway, yes, and you'll note the reason we do the cephalic angle is your foot goes down at an angle, and we're actually trying to match that angle a little bit, and that's the reason we do our 15 degree cephalic angle. You want to include the toes, of course. You want to include the skin margins, of course, and you want to include up into the tarsal bones. Okay. So we've got the phalanges, metatarsals, and tarsals. You want to get the entire metatarsals in there up into the tarsal bones. Toe of interest should be seen independently with no overlap of other soft tissues. No rotation should be present. The shaft of the phalanges and metatarsals should appear equal on either side. Rotation happens when one side of the phalange is more concave than the other. And it's kind of like a finger. If the concavity of the toe is off a little bit, it just means that you're rotated a little bit. Not the end of the world, but it is something that you need to look for. So, and you see these pictures down here. You can see that you can use different methods to show that the toes by themselves. You can get kind of creative doing this. I think maybe that's the reason I don't like doing toes. I hate using tongue depressors and things like that. But sometimes you have to. So anyway, so foot, again, we're going to do a 15 degree cephalic angle like you see in that first picture, because you can see the angle of the forefoot that comes down like that. Okay. Collimation, we want to see both medial and lateral skin margins and distal phalanges. And we want to see posterior to the calcaneus. Okay, we want to see the entire foot, in other words. 55 at 3.5, pretty low technique, give us a nice contrasty picture. The position sponge may be used versus tomb angulation, which is what I've been talking about. We can put a sponge underneath the toes to kind of flatten the foot out. And if you can flatten that foot out, you don't need to do the tube angle. Okay. So be sure that minimal external and internal rotation is present. So you want to, especially on the AP, you want to shoot your flat foot, right? Okay. Ankles. Okay. This is a positioning video that's going to come out a little bit later today. We're going to do an AP, a Mortise oblique, which is a 10 degree internal rotation. Versus a 45 degree oblique. They find that the 10 degree internal rotation shows the mortise view, or the tibial, fibular, and tibial tailor joints a little bit crisper and a little bit better. Okay, and you'll see in that video when that comes out. Technical factors: 55, 60 kVp, 3 to 5 mass. And again, with the ankle, you want to see both skin margins medially and laterally, right? Or if you're shooting a ladder, you want to see the anterior and posterior skin margins. So you want to include about a third of the distal tib fib, and you want your central ray is going right into the ankle joint, right in between the two malleolus bones. Okay, malleolus, however you want to say it. Okay, let's see. Practical point: the distal fibula should be slightly superimposed with the distal tibia. Okay, the lateral and medial malleoli of the distal fibula and tibia are in profile. The tibia-talar joint space should be open. Okay, you need to be able to make sure you're seeing a good joint space opening. And one way to accomplish that is to dorsiflex the foot, or put, like in the second picture there, you can see that foot is pushed all the way back. That's called dorsiflexion. That's something you need to know for test purposes. So the Mortise oblique uniformity of the Mortise joint should be seen without any superimposition of either malleolus. Okay, and this will make more sense once you look at the positioning videos. Okay, tib fibs. Tib fib can be a tough one to fit on one film. Okay, you'll note that the picture on the right, the AP picture, that they've got the image receptor crosswise, which is you can do that with the Paxos 100 as well as any of the other traditional units. Just turn your image receptor sideways and go corner to corner, and you can usually fit your whole tib fib on there. One other trick to fit the entire tib fib in there is to increase the distance of your tube or your SID. So you're going to move your tube up away from the IR, which is going to give you a bigger field of view and allow you to get the entire tib fib on one film. However, if you can't do that, it's okay. Just take an upper and a lower. Just make sure you're including the knee joint and the ankle joint. Okay. All right. So 65 kVp, 8 to 10 mass. Just include the entire tib fib. Okay. Knees are fun. We're going to do 3 views, AP, lateral, and sunrise. Okay. If the patient does not have a patellar type injury or anywhere near the patella, pain by the patella, sometimes you don't need to do the sunrise view. Just make sure you're doing a good AP and a good lateral. And I'd say about 75% of the time you're going to be doing the sunrise as well. So the central ray on the AP, you'll note that on the bottom right or bottom left picture there, you can see that there's a slope that comes off the patella down towards the tibia, right? So we need to match that angle a little bit in order to see inside that joint. So usually we'll use a 5 or 10 degree cephalic angle, and our central ray is 1 inch below the apex of the knee, which is the bottom of the kneecap. So we want to include a quarter to a third of the femur, a quarter to a third of the tib fib, and both medial and lateral skin margins. Okay. Very slim patients may require a slight caudal angle. So you just need to look at your patient. And if the knee is rotated down towards the tib fib, you're going to do a cephalic angle. However, with a really skinny patient, sometimes it's the opposite. So you need to look at your patient and see whether you want to angle cephalic or caudal. Okay. Let's see. The opposite applies for larger patients, which is what we just said. Who require a little cephalic angle. Whether cephalic or caudal, an angle of approximately 5 degrees is adequate. Okay. Patellas, there's different ways of doing patellas, and when we do our knee positioning video, we'll talk about a couple of those. This is one way you can do it. That middle picture right there. There's various ways we can do this on each machine. It is much easier to do on the traditional machine, but very possible with the Paxos 100 machine. So Okay, femur. Femur is a long bone, so we're just doing the two AP and lateral. Okay, and most of the time you're not going to be able to get the entire femur on one film. So, you know, you can do an upper to include the hip and a lower to include the knee on both the AP and the lateral. But as far as positioning goes, just make sure you've got a good AP and a good lateral. Our technical factors are 70, mass a little higher, you know, depending on the size of the thigh muscle. It's, you know, you're going to go 16 to 20 mass or so. So practical point, the greater trochanter should be seen in profile. So you're going to turn the toes in to kind of roll out that greater trochanter so you can see it. Okay. Most of the time, the entire femur will not fit on one image, so you need to take two. You can try the trick of increasing your SID. Sometimes that'll work. If it's a shorter person, you can get the entire thing on there, but most of the time you'll have to take 4 pictures, 2 of each. Okay. Pelvis, hip. So our protocol is if somebody orders a right hip, we are going to take the entire pelvis for our AP. We want to include both hip joints, the entire pelvic girdle we want on that film. And then we're going to do a frog leg lateral of the affected side, right? 0-degree tube angle. So our central ray is at the level 1 inch below the ASIS, or the anterior superior iliac spine. For the lateral, it's halfway between the pubic symphysis and the ASIS. Okay, so you'll note that on the pictures below, this is what I mean by the entire pelvic girdle. You want to see both iliases. Okay, you want to see the SI joints. You want to try and see both greater trochanters. Now, as far as rotation goes on the pelvis, you can look at your obturated foramen down there, the 2 eye-looking things on the ischial tuberosities there. And if those are equal, that means that you don't have any rotation. If one is bigger than the other one, then you do have some rotation that you need to watch. Okay. Practical point, the lateral hip projection, often referred to as a rolled lateral or a frog leg lateral. Can be technically challenging for larger patients. You know, you're going to have to fill a little bit. If you can find that ASIS and put your central ray between that and the pubic symphysis, you're going to be in pretty good shape. Your crosshair is going to be right in the crease of the leg. You want to make sure that your hip joint is visible on your lateral. Okay. Anyway, on your AP hips, when you're shooting the entire pelvis, you want to make sure that the greater trochanter as well as the lesser trochanter, you can see that medially on that middle picture. You want to make sure that those are demonstrated. Okay, and over here on the right, you can see a frog leg lateral. That's what kind of that looks like. Okay, so calcaneus. We don't do a lot of calcaneus. Usually we'll shoot an ankle, but the calcaneus does have a little bit of a different view. It's a PA axial view where you use a 40-degree cephalic angle. On that first picture down there, you have the patient pull their toes back, usually with some sort of band or rope or something. You want them to open that joint. So, and we're going to shoot down 40 degrees into that joint line where the calcaneus meets the forefoot there, or the hind foot, sorry. And then a lateral is just a lateral view of the calcaneus. Okay. So we want to include lateral skin margins anterior to distal third of the foot. So we want to include the entire calcaneus basically. And if you ever get a picture with a fractured calcaneus, they're kind of neat looking. It makes me feel bad for the patient because it's got to be so painful. But you know, if you can get a good AP axial calcaneal view, feel accomplished because it is a tough one to get. They're kind of neat looking. The calcaneus is actually really elongated. They look really neat actually. So if you ever get a chance to practice a calcaneus x-ray, give it a shot, and it'll be interesting to see what you see. So like I say, we don't do them very often, but it's fun to know how to do them. Practical point, although it's preferred to have the patient's foot in full dorsiflexion, sometimes this will not be possible due to pain. In these scenarios, we just need to do everything we can to minimize the pain to the patient, okay, and get the best images that we can. Sometimes they're not going to be able to pull their toes back like that, and you just need to increase your angle a little bit to try and get that joint line. So, like it says there, increase the angle to compensate for lack of dorsiflexion. Sorry, that was kind of long, and it's kind of hard to go through that stuff like that, but it's important that you guys are aware of, as far as positioning, what the angles are and what your central ray points are. So just study those, and we can talk about it, which we will, and get to know those. So anyway, thanks for coming today. Next week, we'll go through some other positioning. But I appreciate you guys being here, and I hope that you have a great rest of your day and a really nice weekend. And, congratulations to Sarah Kane for passing her LSRT exam. That's pretty awesome. So it is very definitely a possibility if you'll put the time in and study and get to know this stuff and use me however you can. So anyway, thanks for coming, guys. It's nice to see you. We'll talk to you soon. See you next week.